All right, so let's move on to the endocrine system with the thyroid. In a nutshell, pregnancy is going to mimic a hyperthyroid state. So there's going to be an increase in body temperature, appetite, fatigue, and then an increase in the size of her thyroid overall as well. So there's an increase in thyroid binding globulin concentration, and there's a decrease in circulating iodine. Some of this is because she's giving it to her baby, and some of it is because our kidneys are leaking more than we need it to. So there's going to be an increased need for dietary iodine, and iodine really is the building blocks for making all our thyroid hormones. So if the body is needing to enter this hyperthyroid state, then the body needs to be able to mount additional work into making more thyroid hormone to meet that demand. So that's where dietary iodine is important. That's less of a concern in high-resource countries, where iodine is often fortified, but is especially something to consider if you are working in more of a low-resource setting. You'll find iodine in meat and in seaweed, fish, dairy, eggs. Lots of seafood would have it. So a couple servings a week of fish is great on so many fronts for pregnancy. Fish oil, iodine. It's actually been found to decrease the rate of preeclampsia too. So nutrition counseling is not something to sidestep for pregnancy care. So thyromegaly, as I said, the thyroid does enlarge. It should be diffuse, though not nodular when you go to feel it. So T4 does rise in pregnancy. That's that increase in thyroid function overall. We need more iodine to make the T4 to be in our hyperthyroid type state for pregnancy. And then it'll go down towards term. And T4 does cross the placenta, and normal neurologic fetal development depends on maternal T4. So that is really, really important, which is why if people aren't able to make enough thyroid hormone, if they came into pregnancy being hypothyroid, or if they become hypothyroid in pregnancy, it's important that we're treating it, because if they can't make adequate T4, their baby's also not getting adequate T4, and that's really important for fetal development. It could be that somebody's thyroid is just kind of borderline okay, and then they get pregnant and their body asks their thyroid to do a lot more work, and their body's not able to rise to the demand that the pregnancy asks of the thyroid gland. And so they might find themselves hypothyroid in pregnancy and need a little bit of thyroid support with T4 supplementation for pregnancy. And then it could be that postpartum, they're able to go back to their demands in their non-pregnant state. It's not currently part of a standard panel in prenatal care to test somebody's thyroid. While it's not currently the recommendation, I definitely know practices that do, and most of the ones I've been in have checked. At the very least, you should have a low tolerance for checking. And it can be tricky because everyone who's pregnant is going to be tired, but trying to discern, okay, it seems like you might be more tired than I would expect. I think we should just check in and make sure that your thyroid doesn't need a little extra support. And so here's your kind of fun fact for the day. HCG in early pregnancy is thyrotropic, meaning it essentially acts like T4. And because of HCG's activity, TSH actually decreases initially because it sees so much activity with the HCG, and then rises to normal by 12 weeks. So you'll remember that feedback loop. TSH is released when you need to make more thyroid hormone. So when TSH is high, then that triggers the body to make more thyroid hormone, and then it balances out again. So if somebody's not making enough thyroid hormone, that's when you would see TSH be elevated. So the classic lab findings for somebody with hypothyroid are going to be low T4, that's your actual thyroid hormone, and a high TSH because it's trying to stimulate you to make more T4. And then even though I called pregnancy like a hyperthyroid state, really, we should just be thinking of it as euthyroid or normal thyroid in pregnancy is just different. We have to have a different definition and a different understanding of what euthyroid looks like in a pregnant person versus a non-pregnant person. And if you do run those labs, you note that they're pregnant, and the lab will give you different reference ranges based on trimester for what you should expect your normal to be. The pituitary gland enlarges as well, and this is due to the proliferation of prolactin-secreting cells. So prolactin levels rise really early in pregnancy, and they'll continue to rise throughout pregnancy. So long as the placenta is in place, estrogen and progesterone suppress and mitigate the effects of prolactin. But prolactin is still being produced, so that's why we've got a larger pituitary gland. Because the pituitary gland has so much action in pregnancy, there's more blood flow to it, and that makes it more susceptible to infarct with a maternal hemorrhage, or even with a dip in blood pressure in the third trimester. So that's especially something to consider in the event of a really significant postpartum hemorrhage. Sheehan syndrome could be on your differential list, depending on how somebody's presenting. And then you'll remember from our menstrual cycle week that our pituitary gland is also what makes FSH, LH, and GH, or growth hormone. And those are all suppressed by placental hormones. So in the context of pregnancy, those levels are very low. And you see that in the menstrual cycle too. So having high progesterone, FSH and LH really aren't produced in the second half of the cycle. And even in the first half of the menstrual cycle, during the proliferative phase, when estrogen starts to pick up about halfway through the proliferative phase, FSH will start to dip a little there too. But basically, high progesterone is going to suppress all of these hormones, and we're not going to see them in high levels during pregnancy. Moving on to metabolism now, the basal metabolic rate is going to increase. So blood glucose levels are about 10 to 20% lower than in non-pregnant people, and there's continued placental transport of glucose between meals as well as overnight. And then pregnancy also has an accelerated starvation in early pregnancy, where basically insulin sensitivity is increased, and that's going to keep blood sugars a little bit lower, and that's thought to have a protective factor. I touched on that a little bit in the context of nausea, but those two seem to be related. So now, thinking back to fetal development, the first half of pregnancy is really about making all the organs, and then the second half of pregnancy is about making all those organs bigger. So in the first half of pregnancy, the pregnant person is a little bit more insulin sensitive, and so her blood sugar is going to be lower, whereas in the second half of pregnancy, her body naturally becomes a little bit insulin resistant, making more blood glucose available for the fetus to help them grow. And then because she's a little bit insulin resistant, she's going to use more of her fat stores for energy in that second half of pregnancy. So then looking specifically at insulin, in the first trimester, there's normal secretions of it. So adipose are more sensitive, resulting in fat storage. And then there's a normal or enhanced CHO tolerance. And then again, 20 weeks on, we see a decreased glucose uptake by muscles and adipose, which means that there's more available for the fetus. And that's really mediated by a whole host of placental hormones. And then if women are unable to secrete enough insulin to overcome that resistance, that's when we see gestational diabetes. This is why we say that if you're testing for diabetes early in pregnancy and it comes back positive, they likely had diabetes going into the pregnancy, and it's not actually gestational diabetes, because gestational diabetes is showing up in the second half of pregnancy, when her body is tipping the scale too far towards the insulin resistance piece here. We're expecting physiologically the opposite in the first half of pregnancy. Of note, in the second half of pregnancy, when she is a little bit more insulin resistant and there's that decrease in glucose uptake by muscles or adipose, exercise enables muscles and adipose tissue to be absorbing glucose without the need for insulin. So especially if you have somebody borderline or just in general, to be exercising in the second half of pregnancy helps to regulate this a little bit more evenly. So what are the metabolism clinical implications for this? So she's got these variations in insulin throughout pregnancy. We're going to see higher spikes in blood sugar, increased maternal appetite, fainting, hunger, tired, nauseous. All of these common pregnancy symptoms or discomforts can be related to the changes in her blood sugar and the shifts in insulin throughout her pregnancy. Pregnant people are more likely to make ketones. It's usually in one of two kind of situations. In early pregnancy, if the nausea is triggering them to not want to eat very much, they may go through long periods where they're not eating, and that can result in ketone production. And then towards the end of pregnancy, when they're naturally a little bit more insulin resistant, they're using more fat utilization for energy, and that can also result in ketone bodies. So it's important that we're regularly counseling women to be consistently eating, to having regular small meals throughout the day, and especially with nausea. Unlike when you're sick, nausea in pregnancy is generally improved when they can get a little bit on their stomach to help kind of even out their blood sugar. So having a cracker with some peanut butter on it generally is going to be helpful, even if it doesn't sound good at the time. And then dieting and calorie restriction can be potentially dangerous to both mother and baby. It's important that we be giving baby a consistent stream of nutrients. So we don't want to have mom be in a constant starvation kind of a state with ketones. We want to make sure that she's able to gain a good healthy amount of weight while she's pregnant, and that her glucose isn't dipping too low. We don't want her feeling faint. So the key here really is that she be getting balanced, good, nutritious foods consistently. By keeping her blood sugar steady, we can prevent crash and burns throughout the day. So we can consider pregnancy to be a diabetogenic state. So even if they don't have full-blown gestational diabetes, there is still some mild insulin resistance there. So now, what does this look like for somebody who has diabetes and then gets pregnant? So this is the pregestational diabetic section here. So in their first trimester, there's likely not going to be any change or potentially a decreased insulin requirement. And that's because their body is already naturally going to be a little bit more sensitive to insulin than it is in their pre-pregnant state. And then in the second half of pregnancy, diabetics are probably going to need 2 to 3 times as much insulin as they'd needed before because of that natural insulin resistant state that they get into. And you'll note that we test for gestational diabetes between 24 and 28 weeks. So that's when we're expecting to be able to pick it up if their insulin resistance is going into hyperdrive. And then initially in the postpartum period, you generally don't need any exogenous insulin. And then by about 4 to 6 weeks postpartum, the needs for insulin go back to about the pre-pregnant state. You'll get into management when you take the antepartum course, but the purpose of this slide really is just to help you kind of understand naturally how insulin is shifting in pregnancy, and especially how that would look for a diabetic quantity-wise. And this would really be a patient where you're collaborating with another provider, whether that's an endocrinologist or possibly an obstetrician. So this would be co-managed care. So in tegumentary, there are a lot of skin changes that happen in pregnancy, and they're primarily due to estrogen drawing blood more to the surface of the skin and those vessels being a little bit leakier. So first up, we have hyperpigmentation. A lot of different areas can get darker or change, so that includes the areola, umbilicus, vulva, perianal area, linea nigra. You can see in that picture in the bottom right, that line that runs vertically across the belly. And scars will typically darken as well. Nevi, moles might change and look different, look darker. Most of what darkens will resolve postpartum, such as the linea nigra. Chloasma is basically where you have darker pigmentation across sun-exposed areas on the face. Sometimes it looks like a butterfly rash. In this bottom left picture here, you can see it across the forehead, where it just kind of looks a little bit splotchier or darker. If you hear the phrase, the mask of pregnancy, that's chloasma. Melasma, you might also hear. Chloasma is just melasma in pregnant people. So they're essentially the same thing. So let's talk about hair. So if they have hirsutism, it's common for that to get a little bit more prominent. So thick or dark hair on their face, neck, chest, stomach, or back. And now let's talk about how hair grows. So for any individual hair, it starts out in a growth phase, and then it shifts over to being in a rest phase, and then it falls out. So we call the growth phase anagen and the rest phase telogen. So for a non-pregnant person, 85% of their hairs would be in anagen or a growth phase, whereas 15% would be in that rest phase or telogen phase. But in pregnancy, the growth phase or anagen phase goes from 85% to 95%. So a lot of their hairs move and shift into that growth phase. So pregnant women tend to have thicker hair, longer hair, healthy hair, best hair they've ever had. That's what you hear about for pregnancy. So now we know that for every individual hair, after it's been in the anagen phase for a while, then it's going to move into a telogen phase and fall out. So then postpartum, you have to have kind of that bigger shift of that 95% that were in the anagen phase. More and more of them are going to end in the telogen phase in order to slowly shift back to that non-pregnant state. So you move from having had really thick, healthy hair in pregnancy to then that hair moving into the rest phase and starting to fall out postpartum. And so it feels like women are having all their hair fall out. And I guess that is true, but it's just because of that ratio of anagen to telogen. So it's certainly a natural cycle, but it can be a source of distress for a handful of women postpartum. Making sure they've got really good nutritional support. They could take a supplement in biotin if they wanted to. A good complex B vitamin, continuing with their prenatal. And then to a certain extent, it's just going to need to be a matter of waiting it out till we reach that ratio of 85 to 15% again. And I actually saw this not too long ago in clinic with a non-pregnant person who'd been on birth control for years with estrogen and progesterone in it for some 7 to 10 years. And she was ready to be done and she went off of it and her hair started falling out. And it was like she'd kind of had her body in a state a little bit more similar to pregnancy with being on the pill, where her hair had been thicker and then to go off of it, she had that shift. So I thought that was kind of interesting. That's the only time I've seen it in a non-pregnant person to have that same kind of hormonal response. And then that increased blood flow is also going to their hands, so you'll see increased nail growth. And so having good nutrition, solid nutrition, their prenatal vitamin on board, all of that together helps ensure that in the midst of rapid growth, it's healthy growth. True for both hair as well as nails. And then, as we said, there's vasodilation towards the surface of the skin with all that extra blood flow going there. That can cause spider nevi. Kind of looks like a spider. I see them the most on the face, though that's probably what I'm seeing the most of patients that are coming in. Palmar erythema, hemangiomas, varicosities, and petechiae would all be due to this vasodilation. So vasomotor instability or like hot flashes could go along with that as well. To be just a little bit itchy would be common for pregnancy. I'll table what potential pathologies around that could be for your antepartum course, but a little bit itchy, common, normal. And then striae gravidarum is what we call stretch marks. Stretch marks are basically linear tears in the dermal collagen, and then that relaxes adhesions and separates fibers. So it's basically just related to distension from the growing uterus, as well as the instability and increased vasculature for the skin. And placental, adrenal, and pituitary hormones all play a role in that as well. Oh, and I meant to say that with spider nevi, it's about 10 to 15% of pregnant people experience them. It's more common with liver disease, in white people, and it's most visible on the neck, chest, arms, and usually it'll resolve postpartum. So with the eye, there is some corneal edema, and that can cause issues with contacts and prescription lenses. She may find that she needs an adjustment with her prescription while she's pregnant. So while there's a little bit of edema towards the front of the eye, if you go deeper into the eye to the back, there's actually reduced intraocular pressure. So corneal edema in the front, but reduced intraocular pressure in the back. Which is why if somebody has glaucoma and they become pregnant, their glaucoma might actually improve while they're pregnant. So beyond perhaps needing a slight tweak in a prescription with contacts or glasses, there really shouldn't be any change in visual fields. So floaters, spots, in general vision changes should alert us to be thinking about if there might be an issue with hypertension. So the quality of sleep as well as insomnia worsen, particularly in the first and third trimesters. So some of that is hormonally and some of it's mechanical. So as pregnancy progresses, it gets harder and harder to find a comfortable position. And then potentially if they're lying on their backs, they may not be as comfortable. That can make them feel nauseous or lightheaded, especially if the uterus is pressing on the aorta some. So if they feel comfortable, fine, but most women are going to feel more comfortable shifting at least a little bit off their back. And then you add in the back pain and the tingling, potential leg cramps, needing to go to the bathroom a lot, and it can just be more challenging. Pregnant people may find that they're napping more throughout the day and have diminished daytime alertness. It may be harder to get into a good deep sleep at night, so increased night awakenings. Restless leg syndrome can also play a role in that. Pregnant people also tend to have more vivid dreams, so sometimes that can even play a role in just their sleep quality. They may even notice more air hunger when they're laying down, with their uterus being able to press up into their lungs more easily. So they might find that it's easier to be propped up a little bit more, add a few more pillows, sleeping kind of reclined in a chair. And there are really good studies linking the quality of sleep in pregnancy to the quality of sleep postpartum, and poor sleep in pregnancy, meaning that it will be poor postpartum as well, and also increasing the risk for postpartum depression. So I really prioritize supporting good, strong sleep and asking about it, particularly in the third trimester. Whatever they can do to improve their sleep hygiene in the third trimester will set them up better for better sleep postpartum as well. So in conclusion, most body systems are impacted by pregnancy. It is not just the uterus. Normal pregnancy symptoms can mimic disease, and some diseases are exacerbated or unmasked during pregnancy because of the added physiologic stress of pregnancy. It's important that we rule out disease processes even as we come across symptoms that may just be signs of normal pregnancy. And again, we want to differentiate between what's common versus normal. So I use the example of back pain. It might be very common to have back pain, but it's not normal, and I want to treat it as back pain. It may be really common to have heartburn, but it's not normal to have heartburn, and there's a lot that we can do to help improve it. So a big piece of pregnancy care is really developing management plans for a lot of the really common discomforts of pregnancy. And then as providers, our stance can just be to be really compassionate and supportive for them in this journey. What a privilege we have to walk alongside women in this journey into motherhood. Whether it's their first or their sixth, this time of transition is precious. Let us love them so well. Let your little clinic room be their safe haven, where they're fully heard and fully accepted in love. May we care about their whole personhood and seek to bring healing in whatever area is lacking wholeness, be that physical, social, psychological, spiritual. Let us be assessing in all these areas and then be treating in all these areas. She could be a woman who is homeless and finds herself unexpectedly pregnant, 3 weeks off her normal street drugs in your office, or perhaps she's pregnant with her second and has a toddler who sleeps in her bed, yet her toddler isn't really sleeping. She's getting 3 to 4 hours of sleep tops. One issue bleeds into so many other holistic components, so that psychological, spiritual, physical, social. Let us be watching for how they all interact with each other and helping to find support and strength for them through this season. Let us help them find their strengths, regardless of their situation, to empower them. Their needs might be obvious, but who is telling them of their strengths? May we be their greatest cheerleaders. All right, I hope you all have a wonderful week, and as always, feel free to send us questions if you have any in the general forum. Okay, have a great week.